Welcome everyone to the Living Well with a Blood Cancer virtual conference. The Leukemia and Lymphoma Society of Canada is proud to introduce this webcast on enhancing quality of life, exploring the multifaceted challenges of the blood cancer experience. In this 75-minute live webcast, we will hear from our panelists who will explore some of the latest LLSC-funded research dedicated to understanding and improving the lived experiences of the blood cancer community, which includes physical, emotional, social, and cognitive well-being, and highlighting how quality of life evolves across the continuum of care. Before we begin, let me introduce myself. My name is Paul O'Connell, and I'm the Research Program Director at the Leukemia and Lymphoma Society of Canada. I will be the moderator of the event today. We invite you to type your questions and comments in the Q&A box of your Zoom webinar panel throughout the presentations. An LLSC staff member will monitor the questions, and I will read some of your questions aloud at the end of the presentation. I would like to remind everyone that due to the large number of participants and limited time, we may not be able to answer your questions, but we will follow up afterwards. Please note that our panelists cannot answer specific questions about a person's health, history, or status. Lastly, today's presentation will be recorded so you can re-watch it again on our website. I'd like to begin first with a land acknowledgement. As we come together from across Canada, we recognize that we are on lands cared for by many Indigenous nations. We honor the First Nations, Inuit, and Métis peoples whose deep connections to these lands enrich our community. We value Indigenous voices and are working to ensure they are truly represented in our leadership and staff. At the Leukemia and Lymphoma Society of Canada, our commitment to diversity, inclusion, belonging, and health equity guides how we work to support and uplift everyone affected by blood cancer. Before we start the presentation, I'd like to share the important mission of our organization. Are you looking for specific programs or resources but not sure where to find them? We are here to help. You can connect with a community services lead in your region to receive personalized assistance and get connected to resources in your area. Reach out by calling toll-free 1-833-222-4884. We know that having a diagnosis of blood cancer can be very overwhelming, but know that you are not alone. There is a blood cancer community that is here to support you every step of the way. As mentioned earlier, you can access one-on-one support to help you navigate the blood cancer experience. On our website, bloodcancers.ca, you will find tailored information and resources that focus on quality of life, such as a section dedicated to self-care and wellness. Our goal is to better serve our community and offer an improved online experience. The information and resources on our website, bloodcancers.ca, are tailored and presented in multimedia formats to address the variety of needs and preferences of our community. This includes fact sheets and booklets like the one you see on your screen, along with podcasts from our channel called The Blood Cancer Experience. Visit bloodcancers.ca to read, listen, and watch all of these great resources. If you're feeling a sense of detachment or isolation, even if you're surrounded by friends and family who care for you, joining a support group may give you an extra outlet to validate your feelings among people who are also experiencing cancer. You will learn from their experiences and have opportunities to share your own coping methods and practical information. All LLSC support groups are virtual and professionally facilitated. Join a group by visiting bloodcancers.ca to register. So on to the presentation today. So today you will hear from five panelists. These are all researchers. These researchers will speak to you today about the research that is funded through our Blood Cancer Quality of Life grant program. We have 4 panelists on today, and Dr. Helen McTaggart-Cowan couldn't be with us, unfortunately, but a recording will be available afterwards. I'd like to very briefly introduce, before we get into the more detailed introductions, Dr. Sandeep Dhillon from University of British Columbia, Dr. Saeed Moradian from York University, Dr. Edith Pituskin from the University of Alberta, and Dr. Stuart Peacock at BC Cancer Agency. So we can move on to this. So our first panelist, Dr. Sandeep Dhillon, will present how older South Asians are managing their blood cancer. Dr. Sandeep Dhillon is a postdoctoral research fellow at the School of Nursing at the University of British Columbia, working under the supervision of Dr. Kristen Haas. She's a member of the Access Lab, where her research focuses on aging, equity, and supportive care. Over to you, Dr. Dhillon.
Hello, everyone. I want to thank you first, Leukemia and Lymphoma Society of Canada, for inviting me to be part of this important conversation. So as you all know, I'm Dr. Sandeep Dhillon, and my work focuses on understanding how South Asian older adults and their caregivers experience and manage blood cancer. And this work kind of began from a simple but very powerful question about how can we make cancer care more equitable, culturally safe, and also responsive to the communities that we serve. Before I begin, I want to acknowledge that this work is being done on the traditional lands of the Musqueam, Squamish, and Tsleil-Waututh peoples. I'm grateful to live, work, and learn here, and I share this project in spirit of community, care, and also respect. And this work has been a team effort. I work with an amazing group of researchers across Canada, and I just wanted to kind of highlight them here. So today, I'll walk you briefly through the context of why this research matters, how we conducted it, what we're learning so far, and then also what lessons are kind of guiding our future directions. So across Canada, our population is aging faster than ever before. By 2030, more than 1 in 4 Canadians will be over the age of 65. So this shift is bringing new pressures to our health and also our cancer care systems. Especially as older adults, they live longer with chronic conditions and they require ongoing support for their quality of life. We can go to the next. And with that being said, South Asians are now the largest visible minority group in Canada, and this population continues to grow rapidly. Many who immigrated decades ago through early migration or through family reunification policies are now entering older adulthood, and with more people are now being aged 60 years and older than ever before. And what's unique is that many South Asians, they live in multi-generational homes where grandparents, parents, and children often live together. So this means that caregiving and health decisions are shared across the family, which really shapes how illness and support are experienced within our communities. So as we see this growing population of South Asian older adults in Canada, it's really important to ask, what does this mean for their health and their experience with cancer care? So first, Canada's population is becoming much more diverse. So more and more older adults are from immigrant or racialized backgrounds, and this means that their care experiences and needs are not the same. And second, South Asian older adults are still underrepresented in our health and cancer research, so their voices and stories don't often show up in the evidence that shapes this care. And then finally, factors like language, stigma, faith, and family roles, they really influence how their cancer is understood and also managed. So for many South Asian families, these factors shape whether people even feel comfortable talking about their blood cancer or even seeking help outside of their family. So understanding these experiences isn't just about research, but it's about improving the equity and quality of life for these older adults and their families. So the main goal of our study was to document how South Asian older adults and their caregivers manage blood cancer. So we wanted to look at what supports do they rely on, what challenges do they face, and what their care looks like at home and in the community. And the significance of this work was to help us understand how culture, family, and community shape that cancer journey. So these insights were really important because they help ensure that care is not only medically appropriate, but also culturally reflective, equitable, and truly aligned with people's lived experiences and their values. And when we started this work, one of the first things that we realized that we needed to think about carefully about how we what self-management even means in this context, because for many South Asian families, managing illness is not just an individual act, but it's a shared one. So we wanted to make sure our definition of self-management reflects the real experiences of South Asian families. So it's not just about one person managing their illness, it's something that's shared with family, community, and also faith. So we use more of an inclusive definition that looks at how people manage their health physically, emotionally, and also culturally. So this figure here kind of shows how we organize 4 parts of self-management. So it reminds us that caring for our health isn't just medical, it's about how people live, connect, and also find that strength. So it takes place from taking their medications, managing symptoms, to relying on their family and community support, to maybe even balancing traditional and Western care, and also drawing on faith or spiritualities. So all of these kind of shape how South Asian families experience and manage their blood cancer. So our study is happening in 2 phases. In the first phase, we did a scoping review. So this just means that we looked at all of the existing research on South Asian older adults and blood cancer. And what we ended up finding was that this was a major gap. There were no studies that have focused on this population, and this showed us how important it was to take more of a community engaged approach. So in the second phase, which is happening right now, we're working alongside community partners to speak directly with South Asian older adults and caregivers. So we're learning about how people self-manage, they seek support, and also make sense of their diagnosis in their own words and experiences. So to make this research meaningful, it's really important that we just didn't study the community, but we worked with the community from the start. So this included connecting with healthcare providers, researchers, and South Asian community organizations to kind of guide how we approach this work. And one of the biggest things we've learned is that building trust really takes time, especially because research with older South Asians is still quite a new concept for many. And what's really worked is that we've been building on our personal relationships and through word of mouth. So this is when one person shares their experience, others may feel more comfortable in getting involved. And our next step is to just strengthening these collaborations between clinics and community networks so we can just continue learning with and from the community. So our community outreach in action is attending like local tea parties and community events with South Asian partners. And this is to share more so like what the study is about in more of a relaxed and an open environment. So, and I was also invited to Connect FM, which is a very a long-standing South Asian radio station that reaches listeners across Canada. And this was just to talk about blood cancer and to help reduce the stigma. And this was all done in Punjabi. So through these connections and through different WhatsApp groups and community networks, we've built that trust and visibility. So it's just been less about that formal recruitment, but more about conversation, word of mouth, and just showing up consistently. So far, we've spoken with 3 women, one in her 20s, another one in her 50s, and another one in her late 60s, and each sharing a different point of view as caregivers for their grandfather, mother, and father. And our connections in the community are growing. A few more people have told us that they'd like to take part and speak with us when they feel kind of ready. And that means a lot because this is very personal and it is a very sensitive topic. We also now have approval from BC Cancer, and around 20 more people have been identified who may want to join the next round of conversations with us. And even with the few stories that we've gathered so far, some of the early messages are really clear that there's still stigma talking about cancer. There's also incredible family support and also strength in how people care for one another, and also how they move between different health systems and languages. And so one of the biggest lessons we've learned is that trust really takes time, and that's okay because building relationships in the community can't be rushed. It kind of grows through consistency, respect, and just showing up again and again. We've also seen how the silence and stigma still exist around cancer, especially blood cancer. Many people are kind of hesitant to talk about it, and which is why these open conversations are so important. My own insider perspective as a South Asian woman has really helped me connect and build that trust, because this work isn't just research, it is personal. And finally, we've learned that relationships do create change. And when communities, families, and researchers do come together, we can kind of start breaking down those barriers and create space for care that truly reflects our values and experiences. And this is just my personal takeaway that, it's really important that we work with, not on communities. Healing happens in having these collaborative relationships, and that change starts when we all come together. So, as I close, I just want to bring it back to one message here, that trust really takes time. Silence and stigma really does still persist. Shared culture does build trust, and our relationships can create change. So, thank you all so much in being part of this important conversation.
Thank you very much, Dr. Dhillon, for sharing your insights. And now I'd like to introduce Dr. Saeed Moradian, who will speak about the symptoms that may predict the onset of secondary effects of immunotherapy. Dr. Moradian has worked in a variety of clinical settings before consolidating his nursing career within the areas of nursing, research, and oncology. He graduated from the University of Manchester's nursing PhD program in the UK. Dr. Moradian's research program focuses on reducing the burden of complex cancer systems and improving the quality of self-management support in the cancer system. Over to you.
Okay, thank you very much, Paul, for introduction, and good morning, everyone, and thank you for being here. I'm Saeed Moradian, Associate Professor at the York University School of Nursing, and it's an honor to be part of this event. And today I'll talk about our LLSC-funded project, a study rooted in both technology and compassion. At its core, this work asks, how can we use real-time data to protect patients' quality of life before symptoms become crisis? Quality of life isn't a signal moment. It stretches across the entire continuum, right? From diagnosis and active treatment to survivorship. And as you know, immunotherapy has transformed cancer treatment, but it's also introduced new and unpredictable challenges. Our goal as a researcher and clinician is to balance innovation with well-being, ensuring that as therapies become more advanced, our approaches to care remain deeply human, attentive, and supportive of the whole person. So as I said before, immunotherapy has changed the landscape of blood cancer treatment. It's reawakened the immune system, training it to recognize and destroy cancer cells. But that same immune activation can sometimes turn inward, attacking the healthy tissues instead. So we call these reactions immune-related adverse events. They can range from mild fatigue or rashes to severe inflammation of vital organs like lungs, liver, or heart. One of the most serious complications is cytokine release syndrome, or CRS, which affects more than um, 190% of patients receiving CAR T therapy. It's a rapid inflammatory response that can progress from a mild fever to life-threatening organ dysfunction within hours. So the real problem isn't just the severity, it's timing. And in many cases, symptoms escalate before clinicians detect them. And current monitoring depends largely on patient noticing and reporting changes, a process that's reactive and often delayed. So this delay can mean missed opportunity to intervene early and prevent hospitalization and protect quality of life. Our challenge then is clear. We need systems that detect risk before symptoms becomes out of control. So the clinical challenge we just discussed, the delay between symptom onset and detection, led directly to creation of VCare, a digital health platform that we developed by supporting the LLSC. So WeCare allows patients receiving immunotherapy to report their symptoms in real time using structured electronic patients reported outcomes or ePROs. These grounded in CTAX criteria, measuring severity, duration, and frequency of symptoms. The system then analyzes these inputs. If a patient's patterns of responses suggest a raise in risk, for example, increasing fatigue with, let's say, paired with, low-grade fever, WeCare sends alerts to clinician or research nurses. So this early warning enables the care team to respond proactively rather than reactively. One of the most important shifts in modern oncology is the move from reactive care, where the response only after symptoms become problematic, to predictive care, where we intervene before complications happens. With WeCare, this shift becomes tangible. Instead of relying solely on retrospective symptom reporting, we are working to use data to anticipate what might happen next. The system's algorithm consistently analyze patients' symptoms trend and physiological indicators, looking for early deviations that may predict immune-related toxicities. Our predictive models integrate both subjective information, how patients feel, and subjective data, such as heart rate, oxygen saturation, temperature, and inflammatory biomarkers. These signals are then processed by machine learning algorithms trained to recognize subtle patterns associated with the onset of CRS and other immune-related adverse events. The predictive intelligence within WeCare didn't emerge in isolation. It was shaped through a deep collaboration process guided by the current clinical guidelines and expert input. The project has bring together an interdisciplinary team, researchers, clinicians, oncology experts, software engineering, and the most importantly, patients themselves. So each partner bring a unique lens, scientific, technical, and experiential, ensuring that the system isn't only accurate, but meaningful and user-friendly. And we are currently working to integrate biosensor, which are capable of tracking, physiological data such as heart rate, oxygen saturated, and inflammatory biomarkers like IL-6, IL-10, CRP, and so on. So We analyzed alongside symptom data, and these parameters help detect changes long before patients become clinically unstable. So our co-design approach ensured that VCare is usable, safe, and relevant to practice. When we think about why this work matters, it's always come back to quality of life. Predictive monitoring isn't just a technological advancement. It's a meaningful shift in how we support patients and families through treatment. Early detection means fewer emergency room visits, fewer hospital admissions, and fewer treatment interruptions. That translates into more stable health, less stress, and greater continuity of care. It also supports adherence and confidence. When patients know their symptoms are being monitored in real time, they feel safer and more empowered to stay engaged in their care. The peace of mind cannot be overstated. It restores a sense of control during an inherently uncertain experience. And for clinicians, this approach enhances communication and shared decision making. Instead of responding to crisis, they can have informed, productive discussion with patient and adjusting treatment plans before small issues escalates. And ultimately, predictive symptom monitoring strengthens both safety and well-being. It aligns with every patient's wants most, not just more time, but better time. Okay, as you know, every innovation brings its own set of challenges, and our project is not it's no exception. As we continue developing and refining WeCare, our focus is on three major areas: data privacy, workflow integration, and clinical workload. As we move forward, we remain guided by a simple but profound principles. Predictive care is not just about algorithm. It's about compassion, foresight, and partnership with patients to help them live not just longer, but better. As we come to close this presentation, I want to bring us back to what truly anchored this work. For me, predictive care is compassion in action. It's about listening better, responding earlier, and caring more deeply. Every piece of data that WeCare collect isn't just a number. It's a voice, a signal from a patient who might be feeling anxious or uncertain. And when we interpret those signals in real time, predictive oncology becomes a bridge between science and empathy. It transforms data into understanding, ensuring that no symptoms, however small, goes unseen. Thank you.
Thank you very much for that presentation. It's a very complex topic, as we know, and especially with the rapidly advancing field of immunotherapy. So I'm sure there'll be questions after the fact for this. So I'd like to now introduce Dr. Edith Pituskin, who is presenting on managing secondary effects of blood cancer. Dr. Pituskin has been an oncology nurse for 40 years. Her career and research is aimed to improve the quality and quantity of life in cancer survivors. Her doctoral studies initially focused on prevention of cardiotoxicity, but expanded to prevent whole body toxicity of necessary anti-cancer treatments. In hematological malignancies, people receive some of the the highest survival doses of treatment and therefore suffer both short and long-term difficult effects. Dr. Pituskin utilizes both qualitative and quantitative methods, including cutting-edge technologies, to learn the optimal ways to detect and prevent these effects. So over to you, Dr. Pituskin.
So just to let you folks know, some of us are a little bit older, and so September was my 40th anniversary as an oncology nurse, and getting old is not fun. But on the other hand, I've really had the very good fortune to see treatment evolution. So next slide, because this is becoming more and more important in terms of the ability for people to receive treatment. Next slide. So it's, again, very gratifying that increased survival rates. But one of the things that has struck me, now I do not work directly with hematologic cancers. I'm a nurse practitioner. Most of my work is in solid tumors. But one of the things that has really struck me is that a 60-40 conversation, the 60% likelihood of getting through very intensive treatment, and then what is the likelihood of being functional? Much of my PhD and other work has focused on cardiovascular effects of cancer treatment, but we're now learning that its function goes beyond the heart. Now, if you talk to a cardiologist, they'll disagree with all that, but physical function goes beyond the heart to the lungs, the muscle, the vasculature. So my interest is really thinking about personalized care, much as our other speakers have commented on, to get the right support at the right time. Next slide. So if you were to look at international guidelines, be saying, well, these are the things that all should happen. And next slide. So I applied for, I want to say 5 years. Of course, this is a little while ago, trying to better understand the autologous patient experience. Because again, not as intensive as the allogeneic, but definitely with a similar hospitalization and debilitation, shall we say. Next slide. So, sorry, let's go back. So backing up, so the blue area is what was the typical trajectory. And then the green part is what my team and I added. So this is the Northern Alberta Cardiac Rehab program. And so they stepped up and offered the very same cardiac rehab as somebody would have received if they'd had a stroke or other cardiac event. Next slide. So what did we find? We found that very strong functional measures such as 6-minute walk test and how quickly they may have walked, not just improved, but it was better than baseline. When I say better than baseline, better than before they had their stem cell collection. Next slide. And this is an example of one of our participants who went through all of this. And my esteemed colleague, Nan, likened it to a chemo attack, not a heart attack. So next slide is when it comes to people who've gone through cardiac rehab, why don't they attend? And it's surprised, cardiac rehab referral and attendance rates are shockingly low. But when we talk to our cancer patients whose rates were exceedingly high, well, they saved me. It was part of what I was told. Another, cardiac rehab and recovery. Without that ability to be able to look at before and after, they had no idea how weak they actually got. And then on the other hand, getting on the other side. So I look at this as a way to merge quantitative, the measurable things, but also the qualitative. How did this affect your life? Next slide. So Apollo is again funded by the Leukemia and Lymphoma Society of Canada. Next. And my primary outcome is to better understand. So can we, with additional nursing support, exercise counseling, and nutrition counseling for a whole year, make a difference? And secondary, make a difference personally. And then secondary outcomes, can we make that into a quantitative measure? Next slide. So this is what the normal trajectory is. And I refer back to the initial second slide where, much as other Canadian centers are, Edmonton is not an allo center, so we must refer. Next slide. So what we aim to add is the ATP, is activity tolerance protocol. So this is basic frailty. Standing up and down, timed up and go, 6-minute walk test. And then with the yellow boxes, can we, if time permits, have some prehab, but definitely the standard 8-week cardiac rehab. Next slide. And then along with that, for those, I provide laptops for those who either don't have one or maybe want one. Provide that, but there's phone support from a nurse, exercise, and a dietitian. Next slide. And again, examples of the app, which includes not just exercise, but if you're locked up in a room for a month, I think anyone would get a little squirrely. So much of that is relaxation, breathing, and other holistic ways to cope with what's going on. So far we found a lot of, practical concerns, and some of that has to do with maybe the amount of time that regular supportive care people, the additional family support. One of the things that's really struck me is that the nurse is not just talking to the patient, but spending equivalent, if not more time with the primary healthcare provider. Next. And so what we've also done is presented some preliminary data. So all of the work that my team and I do use MRI. And so we looked at the first cohort of patients. So we've got 11 on whom we've had the time to look at their data. Next slide. And so if you look at this, it's like, oh, that's all kind of gray and grayish and less gray, and it's more white and black. So what MRI does is look at fat and water. Next slide. But what you can do is tell the MRI scanner and the computer to kind of particulate that out in ways that our own human eyes, we could be looking at that forever and ever and really not appreciate that. So the pixels and the various shades of gray can be automated. So what we're able to do, next slide, is to better understand the fact that there's a very different fat and muscle evolution. So when you think about thighs, slide up. When visceral fat, 91% greater in men. So we have a very large normal cohort. So when you think about cardiovascular risk and death in people who've gone through high dose hematologic treatment, so that's almost 100% more risk in men to have visceral fat. So next slide. And then we also looked at skeletal muscle, so looking at the leg. It actually doesn't really matter. We always worry about the fat rind around our tummies, which is actually not that important. It's the intermuscular and the fat that's within the organs. Next slide. So what we need to think about is how to better understand that. So, and this is very innovative work that my group is doing. So a person tends to think of the marrow as just a place that makes blood cells, but that's not true. So if anyone has had ossobuco, where there's anyway, so it's a combination of hematopoietic cells, but also the fat that supports it. And so we are learning that there's a massive reduction of fat post-therapy. We don't know what it means. We're hoping to, with time, better understand. Next slide. But what we're really looking at, so this is breast cancer patients. And so I call that chemo light, because these people get like a itty bitty amount of chemotherapy compared to people with hematologic diseases. And I don't know, it must have been a vegetarian who did this, because the fat is red and the muscle's yellow. But at the end of the day, we're starting to understand that the increased fat percolation within muscles has a direct effect on how people are feeling and functioning, because VO2 peak, which is the maximal exercise testing, is one of the most powerful predictors of survival. Next slide. So when you tell people, well, how about I put a hose in your mouth and a clamp on your nose? And they're like, I don't think I want to do that. So we've modified our approaches to just measure it while you're walking. And the black thing on the lower left is a thing we put on your calf, and that helps us to measure the oxygen going to your leg. Next slide. So what we're hoping to do is, very much as our other speakers have mentioned, can we find targeted ways? Can we do the right care at the right time with the right intervention? Are we measuring it in the right ways? Because there's the right way and the acceptable way, which nobody wants a clamp on their nose and a hose in their mouth and so forth. But we're learning that this portable walking, and the beauty of that is walking wherever you might happen to be. And can we better understand what is going on with muscle and fat interaction? Because we want people to be cured of their disease, but we want them to do well and feel well and have a full life and do all the things afterwards that they want to do. So to better link, again, symptom report, which we're always asking, please check this off, but also to link that with physical performance. Next slide. So I truly, ultimately, I want to shift that 60-40 to, I want those numbers to be better. I think that there needs to be better we need to be doing better psychologic and physiologic support and providing the right person at the right time for the right needs. And that might be kind of the sugar and spice, depending on where somebody is in their recovery trajectory. Thank you. And this is my team, who are amazing. Everyone's amazing people.
Wonderful. Thank you very much for that presentation. Now we're on to our last speaker of the day, which is Dr. Stuart Peacock, who will present on how to improve the experience of childhood and teen survivors reintegrating into school. Dr. Stuart Peacock is a professor and Leslie Diamond Chair in Cancer Survivorship in the Faculty of Health Sciences at Simon Fraser University. He is a co-director of the Canadian Centre for Applied Research in Cancer Control and is based at BC Cancer. His main research interests include developing more effective cancer services, making health making health system funding decisions fairer and more transparent, and improving the quality of life of cancer patients and survivors. Over to you, Dr. Peacock.
Thank you, Paul. I'm very privileged to be here today, and thank you for having me. I work with Sarah, Zara, Montazir, Helen, Agnes, and Mira on this project over in BC. And like Dr. Dhillon, I'd like to give a quick land acknowledgement to where the work is taking place. And SFU in particular is committed to reconciliation. We are based on the Musqueam, Tsleil-Waututh, Squamish, and Coquitlam lands over in BC. So I'm going to talk today about education and survivors of blood cancers. The impetus for this study came actually from Mira, who is, some of you may even know, who's a hematologist who works out of the BC Children's Hospital. And she had become concerned over the years around how we reintegrate children and adolescents back into the education system after they've received treatment or a diagnosis of a blood cancer. So thank you for the LLSC for supporting this work. And I also have grateful thanks to the Diamond family for supporting all my survivorship work. Next slide, please. So I'm coming at cancer survivorship from the broad definition, which some of you may have seen, some of you may not. But cancer survivorship, we think as being a state of being, including perspectives, needs, health, and physical, psychological, social, and economic challenges experienced by people and their caregivers after a diagnosis of cancer. So the reason I've included this is because this is very broad. This is about how we take a person-centered approach or a family-centered approach and live our lives to the fullest and improve our well-being after a cancer diagnosis. And I put this in because it's only relatively recently that we've started to think about cancer survivorship in these terms. 20 or 30 years ago, cancer survivorship was about, did you make it 5 years post-treatment, without much concern to the overall well-being of the individual in the longer term. So this is where survivorship research has kind of grown from. And we also, and I find this definition a little awkward sometimes, but it's useful, I think. An individual is considered a cancer survivor from the time of diagnosis through the remainder of life. And what this allows us to do is think about everything that happens with that individual over their lifetime following a cancer diagnosis, rather than focusing in just on the kind of active treatment part. And as I said, the key parts of what we've got here is a comprehensive approach. We're trying to reduce treatment impacts. We've had a couple of speakers talk about that already. And I'm interested as a health services researcher in overall well-being. Next slide. There you go. So the research that's being funded by the LLSC is a mixed methods approach, which means that we're doing qualitative work and quantitative work. I'm going to report on work in progress today, mainly around the qualitative part of the work here. So we've been conducting interviews with survivors of childhood and adolescent blood cancers and their families to try and better understand what their educational needs are, what their experiences are. And if you like, sometimes I like to simplify it to say what worked well about school reintegration and what did not work well, with a view to obviously providing a survivor with the tools and the opportunities to live a full and rewarding life after active treatment. There's types of themes that we've been working on in the past: academic continuity, school re-entry after active treatment, physical and psychological well-being, school life and participation within it, and different stakeholders' responses to childhood cancer. Quite often we will use some kind of framework that has been developed in the past. This has been developed at the same time that we've been doing our work, and we're kind of using this to a degree in how we kind of collect our data and think about it. So it's just a nice diagram about how we might think about patient experience and school reintegration. Next slide, please. Here are some of the examples of the questions that we've been asking people. We've conducted 19 interviews so far. We're almost there in terms of what we call data saturation, when we're trying to get, we interview people until the point that we're not getting new themes emerging from the data. But here's some of the examples, of some of the questions we've asked various patients and families. How did you prepare yourself or your child to go back to school? What challenges did you encounter? How did you become aware of resources and supports that were available through school or the hospital? And I would say that that varies significantly across the country. So in BC, we don't have a formal program at the moment for reintegration, and that's probably one of the biggest reasons why we want to do this work. How was communication between you, the school, healthcare providers throughout the child's re-entry? And what additional resources or support would have helped with the re-entry process? Here's just a table of the people that we've been talking to. You can see we've got 19 people so far that we've interviewed. Adult survivors, 5 of them, 11 parents of survivors, and 3 where we had child or adolescent survivors and parents together. A mix of diagnoses and a mix of age at diagnosis. And as you can imagine, potentially the type of cancer that you have and the age at which you get a diagnosis could be very important in terms of how you reintegrate into school. And obviously, we're talking about blood cancers today, but we are also doing work on central nervous system or cancers, including brain cancers. And these ones, those types of cancers may involve radiation to the cranium, and it may occur fairly young in life for an individual. And those, the educational needs of those individuals can be quite significant indeed. So we're working on that as kind of a sister project. And if you look at the bottom, we're trying to get a mix of rural and remote there, though I'm not sure that we're fully there yet. We need to speak to more people in rural regions, I think. So there are 5 main themes that are coming out of the work that we've got, that we've done so far. And I'm going to go through each one of these with a little bit more detail in the next slide. So next slide, please. School reintegration processes are highly complex and multifaceted. I think this is fairly self-evident. We had a whole load of external factors making it much more complicated in recent times. COVID-19 had a major impact for obvious reasons. Educational setting, whether in split classes, French immersion, types of school they're at. Lots of internal factors, age at diagnosis, I've already mentioned, individual challenges, physical, cognitive, etc. So if we have patients who have some kind of chemo brain fog, that may take a long time for that to right itself or address itself. And it also may impact on the rate at which people can kind of learn and the stage at which they go back into the education system. In the long term, there could be lost opportunities, financial and employment barriers, educational attainment challenges, all kinds of things going on there. And we do recognize that we're looking at adolescents here as well as children. So we're going up to 19 years old. And the teenage years and the kind of forming your own idea of self and making friends and socializing and doing all those things that we all do as we grow up and mature, we find that there are different needs at different points in the lifetime depending on when you're diagnosed, because it can be a very complex time for individuals going through high school and the like, and then onto work later on. Next slide, please. Knowledge gaps hinder effective support. So no surprise there, really. There's a lack of knowledge about cancer and school reintegration processes among schools and staff, parents and survivors, and among peers as well. And what we find is there may be better systems set up sometimes for re-entry into school with other types of diseases. But in cancer, we haven't done much of this work yet. But like I said, I do want to put the caveat on that. It does depend on which part of the country you're in. We do worry about negative peer interactions. It's obviously a lot for not only the child who's affected to take on board, but it's also a lot for their peers to take on board. And obviously there's potential for bullying and the like. So educating teachers, peers, and survivors about the diagnosis, treatment, and needs is crucial to create some kind of supportive environment for the individuals going back to school. Communication gaps are a major barrier. Lack of communication occurs at multiple levels: healthcare between the parents and survivors and healthcare institutions, healthcare schools, parents and schools and within schools. And it's been a learning experience for our team as well, because we've had to involve unions from the teaching profession. We've had to involve associations with school principals and the like. And as you can imagine, there are a lot of sensitivities and a lot of issues that we need to talk through in terms of building a better approach to reintegration. Facilitating communication is very, very important. And I think this link between where you're getting your care in the hospital setting or at home and then the education system, that kind of communication and liaison between those different roles is going to be very important. And in quite a few children's hospitals, you already have some of those team members in place there working already with the hospital and the patients. Next slide, please. External supports and accommodations are critical factors. We need some formal accommodation. Sometimes it'll be online learning, short-term one-to-one support to help survivors reintegrate back into school. Again, liaisons, teachers and hospital educators to improve coordination to ensure needs are met. And I would say that, you know, some of the people informing this study more directly in the research team are educators, and most of them are motivated by the fact that they've either had a child themselves or they've had a number of children in their school who had cancer, and they've identified that there is a problem in reintegrating as well. And we do need a supportive community and positive peer interactions for reintegration. Next slide, please. Survivor resilience plays a key role, but requires guidance and resources. And I think we always have a delicate balancing act between how much is self-management and how much do we rely on the patients and families to determine their own trajectory forward with some of these difficult reintegration issues, and how much do we in the education systems and health systems need to step in and help provide some of those things. And obviously that's going to be highly context dependent. It'll vary between families, it'll vary between locations. But there's a partnership that needs to be formed often between the health system, the education system, and the patients and families to actually make all this work. So internal facilitators for individuals include self-motivation, advocacy, selective disclosure, an extra effort to keep up academically. Survivors often develop personal growth and coping strategies, but that's also influenced by age of diagnosis and the timing of treatment during key transition. We are working on developing better materials and liaison officers as we speak. And again, I know there's a good program in Ontario, for example, where some of these things are already in place. Next slide, please. So this is my final slide for today. We are work in progress. We've been able to share some of our initial results with you today, which we're very pleased about. We have a number of other projects on the go, including with Helen McTaggart-McCowan, who couldn't make it today, and Mira Ray, looking at different types of issues with blood cancer, as well as different types of cancer and reintegration into the education system. We will be doing quantitative analysis of education data for BC, looking at things like test scores. Education data is hard to work with sometimes because the testing methodology changes so much over so many years. So we only have a few years at a time where we have the same types of tests, for example, for students. But we're going to have a look at that to see whether there are differences in educational outcomes for blood cancer survivors, and to look at what the determinants of any differences are. Ultimately, where we're going with this work is to develop, if you like, a toolkit or a model or an approach to better support children, adolescents, and their families as they reintegrate into the education system. So I'm going to draw it to a close there, and thank you very much.
Thank you very much, Dr. Peacock. So before we get into our Q&A period, I would like to introduce our fifth presenter for the day. So Dr. Helen McTaggart-McCowan unfortunately couldn't be with us today. She did, however, submit a presentation. So there is a video of her presentation on the mental health experiences and outcomes of young adults and teens with blood cancers that will be sent to you following the webcast. So you'll be able to enjoy that at your leisure. Dr. Helen McTaggart-Cowan is a scientist at BC Cancer and an assistant professor of professional practice at the Faculty of Health Sciences at Simon Fraser University. She earned her PhD from the University of Sheffield and completed a postdoctoral fellowship at BC Cancer and the University of British Columbia. Her primary research interests include cancer survivorship. So please watch for her presentation in your inbox in the coming days, and please enjoy that. So we're going to get into our question and answer period here. So first of all, thank you to all of our panelists for the great presentations. If you can come back on screen, that would be great. I'm going to invite all the participants to send us your questions. There are a few in the Q&A box already. Put them in there as soon as you can, and we'll try and get to them in the time we have left for the webinar today. So you're all on screen, great. And so what we'll do, I'm going to start with the questions, and we'll start in the order that we had for the actual presentations themselves. So Dr. Dhillon, you'll be up first. And we had a couple of questions coming very quickly following your presentation. And so we'll start with those. And so first, I think I'm going to do them in the reverse order they came in, because I think the second one is will help with the first one. So could you please start by explaining how and why there is stigma in the South Asian community around blood cancers? Because I think this really sets the tone for the questions.
Yeah, thank you so much. And like, that's a great question to get. I think what the stigma, why it exists so strongly, is because there's this like socio-cultural belief that like if you get sick, it has something to do with like getting bad karma, or like not like it's a punishment from God. So a lot of people will then kind of keep their illness to themselves because they don't want to be perceived, or kind of protect their reputation amongst like their families. There's also that social judgment that comes through. So that kind of fear-based understanding is what prevents people from even getting the support that they need, because faith and spirituality are at the forefront of how a lot of these illnesses are perceived. So kind of re-educating the community about, just about their health, getting like those conversations just started is a great way to tackle that stigma that continues to persist in specifically the South Asian community.
That's a great answer. Thank you. And so I'll follow this up with a quick question as well. Is this true for other minority populations? I know your work is focused on the South Asian community, but is this something that is common amongst other minority populations as well?
I don't know specifically, because I don't work in other cultural groups, but I do suspect that that is something that does come up. Like right now we're doing like a scoping review, looking at how even just broadly different like people from like Asia look at their self-management of just cancer in general. And what we keep seeing in our scoping review is faith and spirituality being the forefront of how their illness is perceived, or just tackling some of the cultural ideologies that come through. So that's kind of something that we do see, but I don't want to say definitely yes.
It's a very complicated question, so thank you. So so the second question that came in before we go on to Dr. Moradian is there research data that concludes South Asians' experience levels of or types of blood cancers that are different than the general population?
Yeah, great question. And currently there's like a lot of limited population-based research in Canada, or even like globally, that breaks down like blood cancer or the outcome specifically for South Asians. And so most of like the large data sets, they don't capture ethnicity consistently. So that kind of makes it difficult to really draw those strong conclusions. And a lot of like these like what we do know from like smaller studies that like is that our health systems report that South Asians are often underrepresented in cancer research because of like a lot of these barriers that exist, from like, their diagnosis to treatment to that survivorship. And that's all related to like, language, like the stigma, even having access to care is a big thing, like transportation to have someone come with them, or even like these culturally appropriate information or supports. So I think like what our study's trying to do is kind of fill some of those gaps, not all, but hopefully kind of get that evidence going and kind of help fulfill it.
Thank you very much for those great answers. So, Dr. Moradian, we'll turn to you now, and this is obviously a very complex topic, especially with as I said, the rapidly advancing field of immunotherapy, and I'm sure you get lots of questions about this. But we had one question come in through the chat here, which is what role, and I think this speaks to the biomarker tracking and looking at what you're tracking in your system, is what role does an abnormally high heartbeat play in predicting cancer activity? And I think we'll flow that into another question is, can this help to predict who will be more responsive to treatment before even starting a particular treatment, if you're tracking biomarkers in this respect?
Well, okay, thank you. So yeah, it's a great question. One of the things, the biomarkers, and actually we want to measure that because, biomarkers, when change, actually it's show us even before that symptoms, the patients experience that one. So, and not all the biomarkers are the same. They are actually measuring different things. So selecting the biomarker, it's very sensitive, it's very important. And how technology actually unable to detect these biomarkers is very important. For example, we know that ferritin, for example, as one of biomarker that you want to measure that. So it's not just about that biomarkers. It's also about the sensitivity of the technology that you want to use to to measure and detect that one. So yeah, in general, yeah, we are still working on that. How we can actually select the most relevant biomarkers related to specifically to CRS, cytokinase related symptoms, and also working, on the sensitivity of the technology that we can detect. And just, one of the things that we realized that it's another, study funded by NIH. I think it's a $2 million. It's about the aerospace because they want to actually, again, detect the lectin with the astronauts to actually, just to monitor their health. But it's a different things, different, aims, but they're the same technology. But again, the challenge is, first, which biomarkers actually is more related to, let's say, CAR T cell therapy or immunotherapy in general, and then the technology that we want to actually detect and make sure that the sensitivity is high. So, and in terms of temperature, I would say, yeah, one of the symptoms that actually shows up before even the syndrome, the CRS actually detected, it's one of them is temperature. And temperature, just by temperature, many times it doesn't meaningful, but when we actually collect it with some other, like the biomarkers itself, and also the oxygen saturation, all these actually suspect that okay, that the CRS actually is developing. So it helps us to know. So just only temperature is not meaningful.
Thank you very much. And I know this is very complex, but so I assume this is a very highly adaptable system that you're creating here, and will be something that you're starting out with in the immunotherapy field, but something that could presumably be branched out and expanded into other forms of treatment that will, to help anyone that is undergoing some form of blood cancer treatment. Is that am I correct in saying that?
Yeah, exactly. Yeah.
Wonderful. So, Dr. Pituskin, let's move on to you. So very interesting presentation, a lot of complex information coming through in terms of the approach you're taking, and I know this started in the cardiac side of things and for rehab. So is this So I guess let's start with the big picture. What is the key takeaway for this work for the general population? I guess whether they're going through have had a transplant or not. Is this something that most people can use into their, daily activities, whether they have, if they have a blood cancer or cancer in general? And how can this really be implemented to impact future outcomes?
And I really enjoy the way that you phrased that, Paul, because there was a time when I've been an oncology nurse for 40 years. There's very few of people online probably who remember something called participation. And so that was really an important way to get young people moving and interested in movement and things like that. And I think that movement is something that has been lost with the, more pain, more gain, and other things that are happening within our world. So any movement is better than no movement. There's no evidence that vigorous movement, i.e. training for a marathon, is any better than training to go to the shopping center and back. So I encourage people to do all those things. But what we are learning, and that's why I showed the images that I did, was that we are starting to understand that there can be a difference, even with a small modicum of activity, can change your physiology. So our work moving forward is trying to better understand how much, what is the secret sauce? And as humans, we're like, what's the least we can do? Which you really hate to say, what is the least we could do? But when you think about what I don't want to do what the least we can do. It's what's the treatment you're going to get, which is the most a human can tolerate, versus what's the appropriate amount of activity we can do, because nobody knows that. We know that some activity is better than none. And my colleague Carrie has shown that in colorectal cancer. But chemotherapy goes to the lean tissues. Lean tissues are the muscle and organs. So can we better understand the interaction between the muscle and organs and so forth, versus the amount of activity that we need to find that exact amount of treatment? And when you think about, as my other colleagues have mentioned, precision medicine, that's what my team and I are really working on. And I'm sorry if that didn't really answer the question, but that's kind of what we're really passionate about. And I would really invite anyone on the panel to chime in and have their opinions as well. I'd appreciate that.
Thank you, Edith. Yeah, I think it's obviously very important that we move, as you said, movement is key, healthy tissue is key, and it helps every aspect of our well-being, whether our experience of blood cancer or not. So I think we're going to, in the interest of time, we're going to move to Dr. Peacock, and then I do want to come back to each of you afterwards to wrap up and bring it all together. So Dr. Peacock, I want to start, and I think your comment on the knowledge gap and the education aspect of this is key to framing these questions. And I think, can we first explain why a child or adolescent is not just a little adult, and why that has such a major impact in our approach to care? So,
yeah, thank you for that. That's a great question. Children and adolescents in particular who experience cancer have a multitude of other things going on biologically and socially, that as adults we have been through some of those phases ourselves, hopefully in a good way to set us up for success in the future. So we have the biological things that are going on, where we have brain formation, coming up with ability to critically think, independently think, and the like. And as I mentioned there, for many of our blood cancer patients who are young, the effects may not be too dramatic, hopefully, on their longer term ability to reintegrate into school. But for some of the tumor types that we see, particularly brain tumors, where they've had radiation to the head when they're very young, 5, 6 years old, that may leave lifelong learning challenges. But it goes beyond just the kind of formation of your prefrontal cortex, which takes 20 to 25 years, and all the biological things that are going on. There's also the social aspect of it, the business, where particularly when you're a teenager, you're trying to figure out who you are. What is your place in the world? How do I relate to other people? Where do I want to go? And these are transformative things that shape us for the rest of our lives. So, I mean, if you could imagine having your kind of formative years interrupted by a diagnosis of cancer, it's a really big wrench in the system. So, yeah, that's a great question. They aren't many adults. They're going through many, many life-changing things biologically and socially, which makes this a very, very challenging thing to experience for them.
Thank you very much. And we'll do a really quick follow-up before we wrap up here. But have you seen differences based in your approach based on the type of treatment that is being used, whether it's immunotherapy, chemotherapy, or whatnot? Because again, we're coming back to the advancement of treatments and so how that approach differs.
One, and again, this is for our CNS, central nervous system tumors. One is the radiation to the spinal cord or to the brain. Now, that doesn't apply to blood cancers in the same way, but we've touched a bit on the personalized precision medicine and the immunotherapies and the like today. We're beginning to understand what the longer term consequences are of some of these things. And some people respond incredibly well, but others do not respond in quite the same way. And what we're doing, and you've seen great examples of some of this research from my colleagues today, is trying to figure out better who responds well and who doesn't, and what the longer term needs profiles are, if you like. So the short answer is it does differ depending on what type of treatment you get. And some of the treatments we understand much better than others. The immunotherapies still new, so we're still getting to grips with them.
Thank you very much for those questions. And I said I've been actually told that in the interest of time, we are going to wrap up now. So thank you very much for your questions. There are a couple extra slides left, but I do want to end this portion of the webinar with a message from one of our participants here. Is say thank you for all your research showing the importance of quality of life plus patient input and self-management. In my personal experience with blood cancer in my son and in myself, this is vital. So heartening to see this trend. So I think that's a lovely message to end the Q&A with. So we do have a couple of extra slides here to end. If you haven't already registered, there is still time to join the live webcast on Mind Matters, Meet the Experts, Intimacy and Sexuality During and After Blood Cancer Experience, and Beyond Tired, Understanding and Managing Cancer-Related Fatigue Through Physical Activity. We want to learn how your blood cancer has shaped your everyday life. Please take the survey Living with or Beyond Blood Cancer to share your experiences to shape how support changes. We would also like to thank Johnson & Johnson, Jazz Pharmaceuticals, GSK, Amgen, Kyowa Kiran for their support in making this event possible. Please remember that we're here to help you. You can reach us by email, by visiting our website, bloodcancers.ca, or by calling us toll-free. Please note that a short survey will be sent to all participants after this presentation. Please take a moment to respond as it helps us plan for future events. And lastly, thank you again to our expert panels for being with us today. We appreciate taking time out of your busy schedules. And for each of you that have joined us to listen in today, take good care of yourself. Thank you very much.